right, so this video is going to be talking about ventilators, and it's nearly impossible to talk about everything about ventilators and potential complications and nursing care of patients on the vent in one video. So I'm going to be doing a series of probably three that focus on the vent. But I do want to mention before we get started on vent settings, this book. I don't know if any of you guys are taking critical care. That is the course that I'm teaching right now in the spring semester at the University of Tennessee. And so we actually get to go into critical care and take care of these critically ill patients on the ventilator, COVID patients, patients with ARDS. And that ventilator book, it costs maybe $30 or so on Amazon, but it is awesome. It's a great reference. So let's go ahead and start just talking about the ventilator settings, okay? So at the most basic, and go balls over here, I have my water. The most basic things that you need to know about the vent is that there are two major things that we as the providers or the physicians as the providers can control. And that is going to either be volume or pressure. So the ventilator is going to be described as being in a volume control mode or a pressure control mode. So if volume is the target, then we're going to put our ventilator in a volume control mode. This is the vast majority of the modes that you'll be seeing on your patients on the vent. They'll be in a volume control mode. That means that the clinician goes in there and presets a predetermined amount of tidal volume to be delivered by the ventilator with each breath, okay? So the ventilator completely controls the amount of tidal volume. We pull about 4 to 8 milliliters per kilogram of tidal volume. And so we try not to just blindly go in and program, 500, milliliters or whatever of tidal volume. We now want to base that on the patient's body surface area, their weight, height, all that kind of good stuff. So obviously men are going to need, higher tidal volumes. Larger patients are going to need higher tidal volumes. I can't speak today. Smaller patients will need smaller tidal volumes. And so we try to cater that to, this patient's specific needs. So volume control, the ventilator controls the amount of tidal volume. Pressure control, this is when the provider decides, okay, tidal volume is going to vary, but I'm going to set this ventilator to deliver a preset amount of positive pressure with each breath. And so with pressure control, the vent is totally in control of how much pressure is applied, how much positive pressure is applied. So think about it this way too. If the ventilator controls pressure with each breath, it's giving a predetermined amount of pressure, then our tidal volume can vary. And the flip side of that is also true. If we program a predetermined amount of tidal volume, then the pressure that the ventilator has to exert to achieve that preset tidal volume, that is going to vary as well. And those things depend on our patient's condition overall. Normally, a person with healthy lungs, their lungs are very compliant. In other words, they accept the air that you breathe in very readily. Okay, but some patient conditions, let's say ARDS, for example, acute respiratory distress syndrome, significantly decreases compliance. Pulmonary fibrosis, which results in scarring of the lungs, that decreases compliance. And so that makes your lungs less willing to stretch and accept those volumes and that pressure that the ventilator is giving. Opposite of that is COPD. So COPD causes patients to lose all elasticity or distensibility, the ability to bounce back after an inhalation. So that makes the lungs very compliant. So you're blowing into the balloon and the balloon is already way stretched and it just accepts all that air very easily that you're putting into it. And so that is the lungs of a COPD patient. Okay, so COPD, very low elasticity, very high compliance or willingness to accept volumes and pressure. ARDS, pulmonary fibrosis, very low compliance or unwillingness to accept volumes and pressure. They're very stiff lungs, okay? So that is going to go into what the provider chooses to go with as far as, do we want to control the amount of pressure or do we want to control the amount of volume? So when you're looking at your ventilator as a student or as a nurse or whatever, there's going to be a few settings that are just constant. All right. And typically on the ventilators that we work with in our hospital, those predetermined settings that do not fluctuate are in little circles on the right-hand side of the ventilator. So obviously you'll see a ventilator mode. So it'll say something like CMV-V. So that's controlled mandatory ventilation -V for volume control. The other settings that you will see, you'll see a set rate, and this is abbreviated F for frequency. So a rate is pre-programmed in. In other words, how many breaths per minute is this ventilator going to give? Initially, when somebody is first put on the ventilator, it's usually an emergency situation. They've coded or they've gone into respiratory failure. We're going to set that initial rate fairly high, probably around 18 breaths per minute, and then come down as necessary based on the patient's ABGs or their improvement or decline in their condition. PEEP, that's positive end expiratory pressure. We're going to see that anywhere from 5 to 20 centimeters of water. Some patients that need very high levels of PEEP include those ARDS patients. Because with ARDS, you have basically a situation where those type 2 alveolar cells have stopped producing surfactant. That's what makes the lungs of ARDS patients non-compliant. But what you also have is a bunch of fluid that has built up in between the alveolar bed and the capillary bed, separating them. And so gas exchange is unable to occur. So we go in and we set higher levels of PEEP, which gives a little extra pressure at the end of expiration to inflate those alveoli so that they come into contact with the capillary bed and gas exchange is able to occur. Also, you might see pressure support. So if you're in a mode like SIMV, which is synchronized intermittent mandatory ventilation, and don't worry, we'll get into all the different modes and what they mean in a different video. But if you're in a mode that doesn't give complete 100% full ventilatory support, like SIMV, and these patients are allowed to initiate breaths above and beyond this preset rate that the clinician programs in, even if that ventilator is set to a volume target, let's say that patient's breath, the program breath is set to 16 and they're breathing 18 times a minute. Well, those 2 breaths that the patient is initiating above the preset rate of 16, they are, going to be pulling those breaths on their own. The ventilator is not going to be doing the work, but there might be a little bit of pressure support that just kind of kicks in to just give them a little bit of boost, kind of like a spotter at the gym. The I to E ratio. So this is inspiratory to expiratory ratio. Normally, you and I, when we're breathing in, our inspiratory phase is about half the length of our expiratory phase. So in other words, we're breathing out twice as long as we're breathing in. We can play with these settings depending upon the patho of the patient's disease process. So remember when I talked about COPD. COPD causes the alveoli to lose elasticity, so it makes it difficult for these patients to get air out. So they're, doing all kinds of positions like the tripod position, to get that air out. So what we can do here is prolong this expiratory phase to make sure that the patient gets all that air out, so those volumes don't just build up and build up and build up within the lungs. So you might see an I to E ratio of like 1 to 3 on a COPD patient. And then FiO2, this is just fraction of inspired oxygen. We're breathing in 21% FiO2 on room air. Typically, like I said, when we first intubate, it's an emergency situation, the patient's coded or respiratory failure, respiratory arrest, what have you. We're going to start them out at 100% FiO2. And then we're going to obviously come down on that amount as the patient condition warrants, as their ABGs improve. Now, on the back of my super high-tech whiteboard here, I have some things that are going to fluctuate depending upon your patient's condition. So these are also things that you need to monitor and pay close attention to, because these give you really good indicators of how your patient is doing. Obviously, we're looking at ABGs daily at the very least, and anytime there's a change made to the ventilator. So if FiO2 is decreased from 60 to 50%, ABGs needs to be performed about an hour after that change, after any change, okay? Obviously, we're looking at daily chest x-rays. Are those whited out lungs improving? But these are some parameters that you need to constantly monitor on those every 2-hour vent checks. PIP, that's peak inspiratory pressure. So this tells you what's going on inside the patient's airway. It gives you an indicator of airway resistance. We like for this number to stay under 35. If that number increases, typically the patient is waking up, they're fighting the vent, they're getting anxious, they're getting restless. There's a lot of secretions in the ET tube. They're coughing, they're biting the tube. That is a high pressure alarm, okay? P-plat, so that's plateau pressure. This is not going to be displayed constantly on your ventilator. This is something that respiratory therapy has to come in and measure at the end of expiration. And so they'll do a pause and they'll measure plateau pressure. But plateau pressure tells you about compliance, lung compliance. So let's say we have that ARDS patient that lung compliance is very low. The lungs are very stiff. Plateau pressure is going to give you an indicator of, hey, is compliance improving? If compliance is improving, then you'll see this number begin to go down. We don't want this number, peaking above 30 too often, just as we don't want peak inspiratory pressure rising above 35 too often, because both of those things can cause trauma to the lungs. Barotrauma from too much pressure, volutrauma from overdistensibility from volume. So those are things that we need to monitor. Minute volume. So minute volume or minute ventilation, those terms are interchangeable. But what that is respiratory rate times tidal volume. So that tells you what your patient is pulling in terms of volume every minute, as opposed to every breath, which is what tidal volume shows you. We like to see this in the range of 6 to 10 milliliters per kilogram per minute. If it's too low, then the patient's going to be retaining CO2 and we're going to be looking at respiratory acidosis. If this is way too high, that's not good either. That means their drive to breathe is way too high. They're hyperventilating for whatever reason. So if minute ventilation is not where it needs to be, then more than likely the provider will adjust respiratory rate as opposed to adjusting tidal volume. And then finally, this is tidal volume exhaled. Okay, and I always like to tell my students, look at the tidal volume that's programmed into the vent, that what the patient is getting with every breath, and make sure that your tidal volume exhaled, which will fluctuate, is matching what the patient is getting in terms of pre-programmed tidal volume. If not, then that could lead to hyperinflation, overdistensibility from volumes if they're not breathing out what the ventilator is pushing in. So that's another number that you need to pay close attention to when you're doing those ventilator checks, okay? And all these numbers are going to fluctuate, all right? The numbers in the little circles, the settings that we talked about on the other side of the whiteboard, those are programmed into the ventilator and they will not change. All right, I hope you found this video helpful. Go out there and be confident in taking care of your patients on the vent, and I hope you will continue to learn with me.